Okay, Chapter 18, Respiratory System. So with the respiratory system, we get into pneumonia, okay? With pneumonia, if you even look, I always tell students to try to make sure that they code pneumonia, not in specified, but try to find, like, was it aspiration, what organism is causing it? Sometimes there's not, and you will just code regular pneumonia. Now, lobar pneumonia, when we get into that, this describes a specific site affected lobe or part of the lobe of the pneumonia. So a multilobar pneumonia, it affects more than one lobe. So with this, you're going to assign J1 8.1 lobar pneumonia, unspecified organism, if the provider can't identify that. Okay, so the next thing I want to get into, this just talks about all the different types of respiratory conditions. You know, it's a nice little anatomy type background, but I'm not going to read it to you. So with influenza, the other thing with that, it's J09, and sometimes you want to get specific on what type of influenza. Okay, so we also have influenza with other respiratory diseases. So again, make sure you code it very specific. Do not assign influenza. This is another exception. You know, we had AIDS in the past, we had epilepsy. You cannot code influenza if it's suspected, possible, or likely, okay, as an inpatient. It has to state that they have it. Again, keep in mind they use a lot of these for statistics. COPD is very, very common. Again, look at all the different things that are included in COPD. Okay, so again, looking at this COPD with acute bronchitis or pneumonia, J44.0. COPD does not include influenza. You know, you're always going to probably have to code that separately. We have COPD because you'll have to look to see if they're a smoker because you're going to add those, or bronchitis. We have asthma codes. Wheezing alone is coded to R06.2, not to asthma, so keep that in mind. Sometimes you have status asthmaticus, and with that one, the final character is going to be assigned for both types of status asthmaticus. So make sure you, again, code these out to the highest potential you can code them, just for accuracy. Okay, so let's go ahead. We have bronchitis, asthma. Again, atelectasis, it's common finding on the chest x-rays. Keep in mind, it should only be coded when the physician identifies it as a clinical condition and it meets criteria for a reportable diagnosis. So you're not just going to code off the report. Pleural effusion, abnormal accumulation of fluid in the pleural spaces. It occurs with pulmonary disease, CHF. Here is something that you really need to, again, make a reminder of. It's almost always integral to the underlying disease and usually is addressed only by treatment of that condition. So what they're saying, you don't code it separately. So if you have congestive heart failure and pleural effusion, you're only going to code the congestive heart failure. If it's noted on the x-ray report, it's not reported. So the doctor has to make note. Respiratory failure. One thing with respiratory failure, there's so many coded principal diagnosis when this happens, code principal diagnosis when this happens. So my advice for you for respiratory failure is to read through the textbook. There's lots of examples on when respiratory failure can be principal diagnosis. You have respiratory failure as acute, chronic, or acute and chronic combined. You have respiratory following surgery. And here's what I was talking about, sequencing. Okay, so with the sequencing, make sure, you know, here's one example. A patient submitted with respiratory failure and another acute condition. Okay, so let's say a myocardial infarction. The principal diagnosis will depend on the individual's patient's situation and what caused the admission. So the physician should be queried for clarification if the documentation is unclear which two condition was really the reason that they were admitted. So once again, make sure you go through the guidelines of respiratory failure so you know when to go ahead and sync everything together. Acute pulmonary edema. Okay, this is excessive diffuse accumulation of fluid in the tissues. It can be divided broadly into two characters, cardiogenic, non-cardiogenic. One thing to remember, it's included in the following code assignment. So you don't code this extra. So if the patient has rheumatic heart disease, failure, hypertensive heart disease, heart failure, left ventricle failure, you do not also code pulmonary edema. It's also included in the codes for acute MI, ischemic heart disease. Okay, so when pulmonary edema is present along with heart disease or failure, the pulmonary edema is assumed to be associated with left ventricular failure, unless the heart failure is described as congestive, in which case a code for more specific congestive heart failure is assigned. So pulmonary is included in your congestive heart failures, your heart failure codes. Once again, no additional codes assigned. Okay, and these will be different things that will be on the test, so keep that in mind. All right, surgical procedures. There's just a few things that I want to go through here. We do have biopsy of the bronchus. So again, the qualifier is going to be diagnostic. Brush biopsy would be the root operation extraction. We also have a little more on the biopsy. I want to get to our mechanical and ventilation. Okay, so with ventilation, our root operation is going to be assistance. All right, this is the part here that you need to, again, pay attention when you are doing this. So character 5 is for the duration. Okay, how long were they ventilated? Character 7 is going to be for the type. Okay, so that, again, you can see here, our first character is 5, which is assistance. All right, so the other thing that you want to look at is duration. Okay, how long? So character 5 is less than 24 consecutive hours, 4 is 24 to 96, and then 5 is greater than 96. Let's look at the time-wise. Starting time begins with one of these events. If they have an endotracheal intubation was performed in the hospital or hospital emergency room, followed by initiation of the mechanical ventilation. The initiation of that ventilation through the trach was performed in the hospital or the ER. And then here's the last one. The admission of a previously intubated patient or patient with tracheostomy who is on mechanical ventilation. You want to start counting hours on the ventilation only after the mechanical ventilation has actually been initiated. The removal is also part of the duration. Okay, even if they wean them off, so hour on, hour off, you count that as the whole duration time. The ending is the removal, complete removal, discontinuance of the ventilation, discharge or transfer of the patient. All right, so with that, that is going to wrap up our respiratory system.